For joining us this afternoon. We're going to discuss the creation of our Pediatric Peers Program and the Pediatric Residency Program. I don't have any formal disclosures to mention. I just have a couple of informal points. I unfortunately have more slides than time, so I'll try to keep moving quickly. We are going to be talking about feelings today. I'm going to put that right out there. We will not be holding hands. We will not sing Kumbaya, I promise. And just to also note that I really was drawn to this work personally as much as professionally, because I am very passionate about these three, what I call underlying principles of the PEERS program. I don't have the evidence for them. I am not a psychiatrist, but I hope that we can all somewhat agree that, number one, the human brain's negativity bias is very prevalent, it's very sticky, but fortunately it is also quite malleable. Like going to the gym and getting stronger with all of our physical muscles, we can really work with exercise to shift this to seeing the world with more of a glass half full perspective. That when we are feeling good, we are at our most effective. We are more productive, more efficient, more thoughtful, more creative, all those good things. And thirdly, that I do happen to come from a long line, a strong family of antisocial hermits, and yet it's important for us to really recognize that quality social connections do improve our mental health. We're not talking about Facebook or keeping up with the Joneses, but real proper quality social connections. So those are the three, I think, underlying principles for me that really brought me here today. And my objectives are for you to understand the PEERS curriculum in the pediatric curriculum, house staff curriculum, and how and why and what it is exactly. I'm going to just first set the stage for a minute with a bit of the backstory, a bit of our time frame. Going way back to 2017 is when the Wellbeing Champions program was created, and a handful of physicians were selected from all different divisions throughout the system to really start to launch a shift in the culture, both of medicine and specifically within our training programs. And this is despite the fact that there are so many competing priorities in academic medicine, in training, and yet somehow that we incorporate this into our day-to-day work lives. And simultaneously, but separately, the med school had launched its PEERS program, which we're going to circle back to a bit at the end. In 2019, fast forward, I was lucky to be part of one of the recipients of the IME Faculty Challenge grant that we are here to discuss today. So we began that process first with really just a needs assessment and understanding what our house staff had, what they wanted, what they felt worked, what they were looking for in a wellness curriculum. We did that in addition by launching some focus groups, and with all of that information tucked under our belt, we began the designing and planning phase and launched our first PEERS session of the year, ironically at the beginning of 2020. So we had a very robust planning, launching phase right before COVID hit, and then sure enough, March of 2020 was not even 2 months away. So we and the world were, of course, derailed, especially from a well-being perspective. But I am very happy to report that here we are, 3 years later, in January of 2023, the program has actually been sustained and, in fact, expanded. So briefly going back to what the Wellbeing Champions curriculum looked like at the outset, there were these kind of three domains of curricular offerings. And I mention this only to point out that the underlying common theme, which we're going to keep harping on today, is really the value of social connectedness. And in pediatrics, there was a lot of well-being offerings long before PEERS came around. We had fitness options and creative outlets. We've had support groups and problem-solving forums for years and years and years, predating all of this. We've had bereavement and strength sessions and lots of social gatherings. To talk a little bit about wellness, I'd like to recognize that it kind of can be divided up into these various buckets. And this is worth mentioning because whether we're discussing the physical or emotional or professional or intellectual or social aspect or dimension of wellness, they are all well proven. I'm not going to go into the evidence, but just here's a sprinkling to show that greater social connectedness improves each of those distinct realms of wellness, which of course in turn help to improve overall physical and mental health. So that's kind of really where PEERS comes in. Social connectedness being critical to all the facets of our well-being. Here we see a bunch of pediatric residents, I think, showing all the 6 dimensions of wellness on their off time. So why the PEDS peer program? Why did we specifically choose to launch it in the way that we did? Our aims were, though we had these pre-existing formats, the House Staff Forum I mentioned and support groups, those were somewhat perceived to be more venting groups, and we really wanted to have a positive reflection space where people could actually walk away feeling good. We could amplify positive affect. We, of course, wanted to bolster community, as I've already mentioned. We wanted them to walk away with a specific skill from each session. And we wanted to connect or ingrain this notion that physician well-being aligns with the best possible, highest quality of patient care, that those two are not at all contradictory concepts. So our objective, we started out with a needs assessment, like I mentioned, to understand where they were at, what they wanted and what they needed. From that information, we customized a comprehensive curriculum. And then to continue with the curriculum moving forward with a constant reassessment to see what was working and what needed to be tweaked over time. As I mentioned in our needs assessment, the pediatric residents were concrete that they already had a robust wealth of offerings within their program. Not all had been sustained over time. Overall, we found that they were wellness positive, that they were doing well with wellness compared to some other departments and divisions. They appreciated the intern-only gatherings. They felt things got a little bit stickier or sloppier when the full cohort of PGY 1, 2, and 3 came together in other forums. But specifically, they did want more formally structured and goal-oriented sessions rather than some of the free-form sessions that were currently in place at that time. So as I mentioned, we had focus groups to tease this out a little bit further and found, as I did talk about, the existing support groups were not exactly what they had wanted. There were some flaws that they would have liked to see play out differently. They really did want meaningful connections with one another. They preferred specific concrete wellness activities with an emphasis on skills. That was distinct in our findings, and we did cover with them all the specific stressors throughout the residency program. We did collect some baseline metrics, and I mentioned these only to point out that roughly half of residents walked away from House Staff Forum, from support groups, not really feeling better, feeling a little bit spent, and not feeling elevated or uplifted as we had hoped that they could. So what exactly is this PEERS program? It is a trainee-led structured longitudinal curriculum aimed at cultivating well-being, resilience, and community among medical trainees. What does it stand for? Practice enhancement is the part to remind us that self-care is actually a clinical skill. This is not just a personal, selfish endeavor. This is something that we can impart as clinicians. We want to improve engagement. How much meaning do we get in our day-to-day interactions? We want to be our best, be resilient throughout the adversity that is inevitable. And we want to support one another. A lot of these struggles are normal, and it's important for residents to have a venue to kind of appreciate that. This resilience piece I'm going to come back to can be sort of a sticky or prickly term. No one wants to be told that they are not resilient, that they are failing and need to be bolstered. So I do like to just mention that, of course, they very much come to the table with resilience. The system, the medical system as it is, needs a lot of fixing, and that's important to recognize. It's not a broken individual or broken provider. It's a somewhat broken system, as proven here by my very resilient pediatric residents. So what exactly is PEERS? Again, it is an evidence-based set of modules designed to hold space about what is going well, a positive space. While we are learning resilience skills, we are teasing out what a lot of these common shared experiences are throughout residency training, and we're building community in the process. We're going to break down the stigma of self-care. There is nothing wrong with taking care of yourself. There's nothing wrong with having feelings. There's nothing wrong with addressing those feelings and taking care of them. We don't have to push our heads down, and just push through. And trainees can all help each other. We circle back to all these dimensions of wellness that are being touched on. And for the facilitators of these sessions, they themselves are also coming away with a strong set of leadership skills in well-being and in medical education. So looking at it a little more granularly, each session is resident-led. That's the essence really of the program, is that these are peers leading their peers. These are small monthly group sessions. We dabbled with Zoom, did not like it, kept the sessions live only moving forward after that. The facilitators get training both at the outset of each academic year, general group training, and also get trained specifically for each individual module and session. The sessions last for about an hour. We start out each session with an introduction or with some mindfulness. Then we have a guided discussion through the topic and learn a specific or review a specific evidence-based intervention or skill. We try to make some action steps as to how we can use those moving forward outside of this session in our day-to-day. And the facilitators debrief at the end of each session to kind of tease out what was best and what could be worked on. This is our full curriculum, our full session content. We have 12 modules here. Without going into the details of all of them, I do want to give you just a very brief taste of what we kind of cover and a little bit more in depth. We launched the year with a session about our values. This is really to reinforce this personal foundation that each physician brought to the table, how they landed here in the medical field, reinforce what's gotten us here, but also what's going on with us individually outside of these hospital walls, because we have lots of values and it's easy to forget them when you get drowned down in the day-to-day. We have a self-compassion session, for example, because the drive that it takes to get this far in such a competitive field really leans towards people that beat themselves up quite hard, and we overshoot and don't always have the self-compassion I think that we need to be our best selves. Doctors don't have to be so harsh on themselves, and that's what we tease out in this session. I love the ABCs of CBT because this is such a versatile session. It really applies to all walks of life, well beyond medicine, because we delve into all of the classic psychological thinking traps. Things like catastrophizing and jumping to conclusions, filtering in the negative and filtering out the positive, personalization and self-blame. It's a good list, and it really delves into all of those aspects and how we can avoid them and help retrain our brains. So what were we able to show from all of this work? This is some qualitative outcomes from this survey that the residents answered for us, and we just asked them 4 simple questions. What did they find valuable in the session? What did they not like that was ineffective or unproductive? What would they want to keep? And what would they want to change? I'm not going to go through all of it, of course. I have 2 of these slides, but I want to just highlight a couple of the messages that they sent. As far as what was valuable, that the activities are interesting and helps me as an individual, and that it helps me get to know and understand everyone a little bit better. But what needed some changing, and of course this is inherent in really all realms of, I guess, med education and all of their daily tasks, is that it was really hard for them to carve out the space and time and attend every single session as we ideally would hope that they would. Regarding what they wanted to keep, learning how other people handle various situations, various challenges in their training, and participating with multiple PGY years, having all the 1s, 2s, and 3s come together and share their different perspectives from their different levels of education. And continuing on, again, what they found valuable was learning new skills, having an open space to talk, seeing my fellow residents open up about how they're feeling and thinking, and really using a different part of the brain than what we're usually using in the workday, and connecting on a deeper level. This part, of course, very valuable, realizing that experiences are shared and leaving us with a tool to use to work on all that. The limits, again, this is the limitations column, was that the session itself very much depended on the group's engagement. So as long as the group was very engaged and willing to share, things went quite well. Parts that they wanted to keep were the openness of the discussion, that it was a very supportive environment with a lot of positive outlooks. And the changing part is to remind us that they wanted the sessions to really focus on a try this today with the new tools that we were walking away with. With regards to the expansion of the program, starting here back in December of 2020, we were just the lone wolf in all of GME. We were the only peers program in pediatrics, but going into the following academic year, we had expanded quite nicely. There were at that point 7 different peers programs in different divisions throughout the system. 35 sessions were hosted in total that year, reaching not quite, but more than 364 residents overall had participated, residents and fellows. And now into this year that we're halfway through, it seems that we are on target for a similar level of engagement. And hopefully we'll even reach perhaps more, as much as 400 residents and fellows this year in total. So that is how the program was able to expand, which I think is the most exciting part. These are the 7 programs that are currently hosting peers curriculum within their well-being curriculum. And what the other programs outside of pediatrics have had to say, a bit more qualitative data. I just want to harp on, we only think about the patients that we've failed and not the ones that we've helped. I've realized I never thought about my work in this way. I feel like we don't get enough time to reflect on our values. I'm realizing how universal perfectionist tendencies are. We got to a place of agreeing that it's okay not to know, and agreeing that we can all become more comfortable with this over time. And again, that the peers conversations were really a safe space for them. And it was the creation of a safe environment and the appreciation for sharing their shared experiences that they very much appreciated. Circling back to the med school peers program that began long before us in 2017, I think this is quite exciting. They published this just last June. And the relevant parts for me that I want to highlight is that 3/4 nearly of all of their respondents agreed with the statement that peers has helped me realize that I'm not alone in what I'm going through. More than half felt that the peers program had helped them reflect on their stressful experiences. Nearly half had endorsed that peers has given them structures or words with which to frame their experiences. So who are these partners in crime with me? I want to give a big shout out to Drs. Feingold and Hart, who were the resident and med student team duo that got this all rolling in 2017. As they've moved on, they very much have passed the baton to the wonderful Dr. Jackie Hargrove, who is now overseeing the peers curriculum for all of the 7 programs that we mentioned, with the assistance of Patricia Makatsaria. And that is my session. Thank you so much. Any questions? And please complete the evaluation in the chat box. Those are my very well residents.
Thank you, Dr. Brody. Thank you very much. For the interest of time, we're going to take one question because I want to make sure Dr. Mohanraj and Dr. Strother have time as well.
Yes, please.
All right, Professor Strother, do you have a question?
I noticed that at the beginning you talked about how one of the feedback that you got before you started this was that they liked the intern-only sessions better than the multi-level sessions. And then this one, it seems that one of the things they preferred was having all of the different level residents together was an advantage to them. Can you speak to that difference? Do you think?
Absolutely, thank you. Yes, so I think in the stuff that was going on beforehand, there was more forums like Health Staff Forum, where they kind of felt that they were maybe more competing to be heard, or that the ones were, let's say, being drowned out by the older years. And that this session, again, is different in so many ways, but one of which being that there's a much more equitable distribution of contribution and voices. And so they are more benefiting from hearing what their 2s or 3s had already gone through. But yes, that's a great point. It's just a completely different style, flavor, situation. But yes, thank you for that.
All right, thank you, Dr. Brody. All right, so we're going to move on. I'm going to introduce Dr. Mohanraj while Dr. Brody brings her slides down. Dr. Mohanraj is an associate professor of medicine and medical education and the associate program director for Mount Sinai Morningside West Pulmonary and Critical Care Medicine Fellowship. She graduated from University of Connecticut School of Medicine and did her medicine residency and chief residency at the University of Chicago. She completed her pulmonary and critical care fellowship here at Sinai and has received awards for teaching excellence, leadership, and innovative curricular design. Dr. Mohanraj's academic interests focus on curricular development, physician trainee well-being, and bioethics improvement and education. Her longstanding Humanism in Medicine series received a 2017 American Thoracic Society Innovation in Fellowship Education Award. Dr. Mohan Raj serves as an ombudsperson, as co-chair of the Mount Sinai Morningside and West Hospital Bioethics Committee, and a core member of the APCC MPD Education Committee. Welcome, Dr. Mohan Raj.
Thank you, Dr. Crani, and thank you to you and to the IME for inviting me today. It was such an honor to be a recipient of this grant, and I'm very happy to present on our my work, which turned into our work. My current co-chair for this program, Dr. Brandon Varamis, is also on the Zoom. This program is called Fellows as Educators: Development and Implementation of a technology-driven teaching scholars curriculum. I'll refer to teaching scholars curriculum as TSC for the remainder of this talk. I have no disclosures to report. So I won't go through this whole slide, but I think most everyone on this call is familiar with what goes into having a medical educator skill set. I think we can all acknowledge how important teaching is and critical to the practice of medicine. And our graduating fellows who are at the tail end of their training are increasingly expected to have skills very specific to the medical educator. I think across the country, most fellowships do their best to train fellows as educators, and we often recruit very naturally capable teachers, but most fellowships lack structured programs on how to educate these future educators and to give them these components of the skill set. We also know from the literature of the few programs that exist at the fellowship level that trainees who participate in a TSC can improve their teaching skills. They can also improve scholarship productivity, and therefore they can jumpstart their careers as clinician educators. Integrating a TSC into a fellowship training program has been done. It's feasible, but the few successful models rely heavily on in-person education. Utilizing digital education technologies can improve instructor efficiency, self-directed learning, and knowledge and skill retention. So the teaching scholars curriculum that are generally described in the literature are predominantly in the resident level, and we have a longstanding curriculum here at Mount Sinai at the resident level. We recognize that there are constraints that are very specific to subspecialty fellows. They have a higher clinical burden. Many of them are traveling intersite in a system like ours, and they're in their final training opportunity. There's a lot to squeeze in there, particularly in the last 2 years of fellowship. But we still identified subspecialty fellows as our target learners. They are mature, they are very proximal to career selection, they're very proximal to student and resident needs, and they have an exposure to a breadth of teaching opportunities. So we really thought that they were the best type of learners to engage in the teaching scholars curriculum. So the aims of this project were to develop and implement a technology-driven teaching scholars curriculum utilizing a blended learning model. And in doing so, we planned that scholars would develop expertise and experience in the method and practice of teaching healthcare providers, that we would prepare teaching scholars curriculum scholars for careers as master clinician teachers and clinician educators, and that we would be able to also increase opportunities for our faculty who are not facile at developing or conducting digital teaching, and develop new skill sets for tech-driven education. So I'll just walk through a little bit of the course development and delivery. So we developed a 14-month, 14-module course timeline, and the 3 broad categories of topics we covered were teaching skills, curriculum development, and career advancement. And I'll show you a more detailed slide of this a little bit later. Our scholars were provided with a monthly timeline in which for each module they conducted some pre-work, they had assignments that were specific to the module, they worked through either an asynchronous or a virtual education module, they had virtual check-ins with the mentor of the month, and then they completed post-module surveys, some of which were content-based, but most were general. Based on the module topics, we recruited multidisciplinary system-wide faculty who had pre-existing subject matter expertise, and we paired them with a tech mentor. Now, that's a fancy word for me and Brandon, who basically ramped up our technological skills and worked closely with each of these faculty members to help them to transform the traditional content that they already had into either asynchronous or virtual teaching modules. We delivered this using the Blackboard LMS, and the tools that we used, video conference, of course, we're all familiar with for the virtual modules and check-ins, but for the asynchronous modules, we utilized a program called Storyline 3. And if you're not familiar with this, I think about this as if PowerPoint kind of melded with the Energizer Bunny. It has tons more interactivity, it has tons more features. Honestly, I think we have a lot more to learn from this tool, but it's really a phenomenal way to educate and a phenomenal way to develop some asynchronous modules that can still be interactive. There was loads of interactive features that we utilized, everything from games and quizzes and the surveys to knowledge check-ins within the asynchronous modules, in-module reflection exercises, and one of our faculty, Dr. Goldberg, even incorporated a choose your own adventure pathway. So it was a lot of fun to be creative with this and to think about teaching in a new way. So who were our recruits for this course? As you heard, I'm the APD for the Palm Critical Care Fellowship at Morningside West and BI, and we had some ripe volunteers from our very own program. Dr. Imran Chisti, Dr. Natasha Garg, Dr. Rastik Gorbatov, and Dr. Fernando Vasquez, all of whom were budding clinician educators and who really wanted to be engaged not just as learners and scholars, but as critics of the program as we developed it and tried to ensure that we were optimizing it as best as possible for the fellow level. The fellows are all in the same program, but they work at geographically distanced hospitals. And as I mentioned, they volunteered for this opportunity. We did have a COVID delay of several months, and as a result, one of our fellows, who was a third year at the start, was unable to complete the program. But what we did do is two things. The fellows completed surveys at the end of each module. I won't share all of that data because for an N of 4, there's not a lot of sort of outcomes that we can take from that. But the surveys for each module were generally very positive, and the areas that were a little bit lower had to do with the technology glitches, which we were able to fix along the way. But we conducted batched semi-structured interviews every 3 modules to sort of gain near real-time sort of feedback. And we collated the responses according to Kirkpatrick levels. So I'll share some of these. In terms of participation reaction, as I mentioned, due to COVID, one of the fellows was not able to complete the modules due to graduation, but the other 3 learners completed the entire course and all aspects of each module. In terms of satisfaction, the comments were that they found it feasible and engaging. They felt that a month per module was sufficient time, and they felt that the interactive sessions were a safe space, particularly because a lot of these topics were very new to these fellows. They generally found the assignments relative, although a little challenging when they had to find somebody else to work with. So some of the assignments called for them to identify a med student or resident to sort of teach some of their new skills. They really valued working at their own pace. And as I mentioned, some of the tech was a little bit clunky, but we were able to fix that along the way. In terms of knowledge and skill and behavioral change, they anecdotally reported very valuable insights into their own personal teaching styles and identified their own areas for growth. They felt there was ample opportunity for self-reflection and real-world application. They felt that their strongest knowledge acquisition was reported when they linked it with interactive exercises or assignments, as opposed to just listening to a voiced-over lecture. Very important was that they found the curriculum development modules very helpful, but because this was a development and implementation cycle, we did not pair it with a scholarship project. And so a lot of what they learned was very theoretical, and they really wished that it could be paired with a scholarship project in the future. And then finally, for that to happen, they recommended that all of the curriculum development modules, how to perform a needs assessment, how to identify, how to develop a survey, et cetera, that all of that information be shifted to the start of the course. In terms of broader outcomes, I think we were really pleased to have a variety of new, high quality, sustainable, technology-driven modules that could be used independent of this course. 7 of the faculty engaged developed new asynchronous modules for the first time, and this is something that is reportable on the Mount Sinai CV structure. For our graduating fellows, One of them was recruited to a Mount Sinai Hospital faculty position, and we also recruited him as TSC faculty for this current year. One of the fellows took on an academic fellowship, and then two of those fellows, they accepted community hospital appointments. I will add that they're both outstanding educators, and their visa limitations prevented them from taking on a faculty position. So this is just a snapshot. Each faculty member received this feedback form after their module. I'll admit that they were a little delayed, and this cycle we've been much more timely about sending these out, providing the feedback from the fellows, their survey results, and then specific de-identified sort of feedback from the semi-structured interview groups. So from cycle one, our conclusions was that flexible engagement of time-constrained, geographically distant scholars is possible. Learner participation was enhanced by the interactive in-module exercises, virtual check-ins, and self-pacing. Curriculum development modules should be paired with a medical education project, and that truncating the course to 12 months would really allow for more convenient delivery within the academic year. Our scholars graduated with knowledge, skills, and practical experience to launch their careers. And as I mentioned, 7 faculty developed new asynchronous modules suitable for standalone or in-course education. I think what's great about this is that the modules can form the backbone anywhere for a clinician educator track, but particularly in programs that may lack the breadth of educators that we have in the Sinai system. This is a really great opportunity for self-paced learning that can be scalable to the demands of a clinical fellowship. So we were really pleased with sort of the outcomes from cycle one, and even more pleased that for cycle two, we are growing. We were, shared a lot of our outcomes broadly at the IME Research Day, and we're very excited to have support from Dr. Lightman, providing a little bit of support in terms of growing and providing some resources for our new scholars for cycle two. We also recruited some new faculty, Dr. Farouk and Dr. Rao as our clinician educator advisors. And I want to give Dr. Shah and Dr. Patrawala a shout out. They've been partners with us advising on the development of the curriculum from the start, and also joined our selection committee for cycle two. So this is our current class. We had 22 applicants for this cycle, and we reviewed them based on their specialty, their site, their demonstrated commitment to medical education, areas of interest for scholarship, background, and journey traveled. And as you can see, we're really pleased to recruit a diverse group of trainees, not just by their background, but by their specialty and by their site. I won't go through this whole table, but this is the curriculum for this year. And what you can see highlighted in the box is what's new, which is the scholarship component and the clinician educator advisor component. And this has been really tremendous. The fellows have been developing in real time, along with their curriculum development modules, their individualized scholarship projects. And it's been really, really exciting to see them develop this in a really organized, sort of structured, evidence-based fashion. We also devised a sort of more formal mentorship sort of umbrella here, so that the fellows or the scholars, I should say, are not only just getting mentorship monthly from their faculty members throughout the course from myself and Dr. Varemis, but also in pods, being able to share experiences and ideas for growth with their clinician educator advisors, and on a weekly, monthly, or bi-monthly basis with their local scholarship mentor. And that's a faculty member who's hyper local to their program, advising them on their scholarship. This is just one example. Dr. Erica Park gave me permission to share a snapshot of her research. I won't go through the whole research, but I'll read the quote that she shared. She said, "The TSC is my first formalized exposure to medical education. It has been tremendous in helping me organize my thoughts and ideas into a concrete project. I have enjoyed learning about the various ways to measure the outcomes of my project and how to report these findings." In-person engagement, this is always a challenge, and I think we're all struggling with this as we continue in a more and more virtual and hybrid world. And especially when we hear a talk like Dr. Brody's, and how we understand the importance of social connectedness, it's something that's very, on the tip of my brain. But we're starting out, at least now that COVID is a little bit subsiding, with a networking luncheon actually in a few weeks, hoping if barring any issues with the strike. And then I think we're trying to plan some additional social and networking events, but it's certainly been a challenge with fellows from different specialties, different sites, to get them in person in a room together. And then finally, I am just deeply indebted to this group of faculty. First and foremost, Dr. Karani, Dr. Fowler, thank you for taking the chance on this project that had never been done before and providing us with this grant. And to both of you and the rest of the faculty here, really everybody here is doing this work on their own time without added compensation, just because they love to be educators. And we are so, so grateful that everyone here has agreed to continue in cycle two, and perhaps in perpetuity. We'll talk about it every year with each person. So that is my presentation. I'm happy to take, if we have time for questions, otherwise we can save it till the end.
Thank you so much, Dr. Mohan Raj. We'll take one question again. Anyone, if you could just raise your virtual hand or pop up on the screen for me, that would be great for me to see you. We have a lot of people attending the Grand Rounds today. All right, we'll let you stew for questions, and we'll take them at the end, Myrna, so hang tight. All right, our next presenter is Dr. Christopher Strother. He's the chief of the Simulation Division for the Department of Emergency Medicine and director of undergraduate simulation for Icahn Mount Sinai. He also serves as fellowship director for the Emergency Medicine Simulation and Medical Education Fellowship, and clinically, he's the director of pediatric emergency medicine here at Mount Sinai Hospital. Dr. Strother has been a leader of multiple simulation and emergency medicine national committees and academies, and has given many talks, panels, workshops on teaching simulation, adult learning, and debriefing techniques. So welcome, Dr. Strother.
Thank you so much. First, just somebody give me a thumbs up. I have the right slides on the screen and the right presenter view. Excellent. Thank you so much for having me. As you heard from my other titles, you can imagine how much sleep I'm on this week, but I'm super excited to be here and really grateful to everybody for the opportunity to do this project and to talk about it today. We're going to talk about using an interactive online learning module for procedural skills. So taking something that I would normally teach in the lab on the table and working on it online at home in a little bit of a novel way. The question was, does an adaptive learning module, and we'll talk about what that means in a second, lead to similar learning to traditional methods, or is content being missed? Because this is an adaptive model, I can skip over sections that I think I know well or that I perform well on. And does this generate the same, better, or worse outcome to a more traditional method? As we know, as a med ed talks, we have to throw a little bit of this on here, is learning styles, right? Some folks are visual, some are auditory. The simulation world where I work in is a much more kinesthetic realm, right? Activities, motion, physical activity, physical touch and contact with things versus reading versus a visual or auditory way of learning. We have to always think about this as an educator, right? Not every curriculum lends itself to the same tool, right? Not every learner lends themselves to the same style. So we have to always think about a little bit of everything when we do these things and sort of putting a variety of this into what we're doing. And I'm always looking for some creative ways to contact my learners in different and new ways. So what is adaptive learning? This is sort of a summary diagram of what it would look like, but essentially what we're trying to do is personalize the lesson, right? Is make the activity tailored to the specific person. The way that we do that in this sense, or the way we used it, is rather than a linear module where I go from this step to this step to this step to this step, what this adaptive learning idea is, if I do really well in this step, I could skip the content on that and move a little faster through the module. So things that I'm good at, things that I feel good about or perform well on, I don't have to review again. I can move and really focus on the content that I need the most help in or feel like I have the least confidence in. And this really creates sort of a tailored project and a tailored module, and every learner gets a different experience out of the module. From a learning perspective, right, this is sort of where we were looking at the bottom of Bloom's taxonomy to start with, right? What do you remember? What do you understand? I'm going to ask you questions about it, see if you remember what we talked about, and if you're in that bottom part, but then actually being sim guys, Jared and I wanted to reach out and bring you in and analyze, can you apply that knowledge as well, right? Can we demonstrate it, not just get it right on a multiple choice question, but then come in and do it, right? Because we really wanted to take what we were doing from an online, from an interactive platform into real life. And can I get you to improve on a physical skill by doing these modules online? This is a little version of Kolb cycle that sort of shows the same idea. We were really focused on this top half, this prepare, improve, giving you the information, preparing you to do the procedure, showing me, you proving to me that you know the knowledge, and then coming back and actively participating and proving that you have that in a physical way. So what did we do? So we actually used Storyline as well, which I'm really excited to hear Dr. Maharaj say that. So 2 out of our 3 projects are involving this same software. So maybe this is a technology we should be talking more about. We use this to create an interactive module. And the way it essentially works is we start with content, multiple choice questions, a little bit of an analysis of what you know and you don't know for each step. We did 2 procedures. We're looking at lumbar puncture, where you can see Jared demonstrating on the bottom left of the screen, and central venous line placement, right? So central line placement. And we started with questions at each step, right? Preparation is first. Do you know how to set up the kit? Do you know which equipment do you need? Do you know how to do it? And we run you through some questions. If you got them all right, you skip the section on how to do that part of it and then go to the next section of the procedure, right? Placing the patient in the correct position, for example. If you missed a question, then you would get presented that content in whole. And that content would be a lot of different things. It was primarily either video demonstrations or audio on top of presentation. So we'd show slides, talk about learning points with audio in the background, a lot of Jared talking, and I owe him quite a bit for all of his voice acting and participation in this, both as a concept and assembly. He is the real wizard of Storyline in our group. So you would go through each step all the way through, and you would sort of, if you could get it all right the first time, you whip through this very quickly. We left the questions challenging enough. Very few people were able to do that. So you did end up reviewing good bits of the content, but you didn't have to review all of the content. So what we wanted to do is bring our volunteers in. These are residents and faculty. Most of ours ended up being residents to do these 2 skills. We wanted to bring them into the sim lab on the task trainer, show me central venous catheter placement, show me lumbar puncture, step by step, every bit of the way in the right order, try to give me a perfect demonstration of the procedure. That was our baseline assessment, right? Then we wanted to randomize them to 2 ways of sort of reviewing the material and getting better at it. One was these interactive modules online. The other was more of a traditional published article on how to do the procedure step by step. There's a lot of these out there. AAMC has a bunch of them. There's a few different materials out there that you can use. We chose ones we felt were really robust reviews of these 2 procedures. And we wanted to see if I went home and did this interactive module, and then I did the paper module on the opposite procedure, and then I bring you back, does one benefit you more than the other, but also asking about sort of how they felt about the actual module itself and how it performed. Then we're going to bring them back. Schedule return to demonstrate the 2 skills again and look at their performance. So we get a little bit of a pre and post, but also sort of some feedback from them on the module itself. And then COVID. This is a story that's happening a lot here today. And so this blew up our post assessment. We really were not able to bring folks back for a second assessment in a timely way. And then some of them started to graduate, and then some of them, it got to be kind of a long time, so we didn't really feel like it was fair to bring somebody back, a long time after they received the intervention to measure whether it worked or not, because it would be becoming too many factors. So that was one thing. And then the other thing that blew us up a little bit, we got a little bit of surprise on our pre-test. And this is a lesson maybe in setting your objectives and really looking and doing those needs assessments ahead of time. The 2 procedures we chose are both reasonably complex but fairly common procedures the emergency medicine residents do. If I can get one person to unmute and tell me, which of these 2 procedures would you expect? A central venous line placement or a lumbar puncture, a spinal tap, for the residents mostly, or our subjects, to perform most reliably, like the most likely to succeed on the checklist for those 2 procedures.
LP has less steps, but they do it less frequently.
See, no Steele, you can't take it both ways, but you're 100% right. Very good. Thank you for the participation moment. Look at this. So we were actually a little bit shocked with the residents we brought in. Virtually 100% performance on the central venous line. And this did a couple of things to our study here, right? Is one, we were just really surprised. In the lumbar puncture, which is technically less steps and a little bit simpler, there were a lot of things just setting up the kit and the angle of the needle and the placement and of the bevel. And there were quite a few things where they really struggled. And so very few of them were able to kind of go right through the procedure without guidance, without help on the pre-test. So unfortunately, from the earlier slide and our COVID friend, I don't have the post-test, but I wonder, and actually from a medical education perspective, and if anyone wants to have a cup of coffee and talk to me about how to, I do want to come back to this. What do you do when your pretest is 100? Right? What do I do with that? Is it even worth the repeat part of the study? I'd love to get an 80% procedure, something that's hard to improve. That would be a nice thing for my demonstration of effectiveness, but 100 kind of messes you up, right? And so, 20% gives me a lot more room to gain. But again, maybe a lower bar for actually improving the procedure. So this was a pretty interesting finding we found, just to share with everybody, sort of unrelated to the actual module. But the module itself, essentially 100% scored is excellent. 4 out of 1 to 4 rating. People thought 4 out of 4. People really liked doing these online modules, and the reading material, which we selected the best ones we thought were rated not so great. Right? They didn't really, level 1. Did I like doing the course? Right? They didn't like doing it so much. However, interestingly, the online modules, despite their adaptive nature, took 20 to 30 minutes longer than the reading material. And these are, if you imagine, if I can get an emergency medicine resident to spend more time on something and like it better, we think that's a big deal. Because keeping their attention for length of time is often a challenge. So we're really happy with the material, and we're still using the modules, and they've been really successful and well received, and we've made some tweaks of them over time. So we feel very happy with what we built, but our sort of follow-up was a little hampered. So in conclusion, residents, our first finding was that residents could not complete a procedure that we thought, would be the easier one, and did really well on the one that we thought would be more difficult. So a really nice sort of learning moment for us in our program. Adaptive learning modules were positively reviewed. People actually liked them over sort of a more just like basic, here, read about the procedure sort of thing, even though it took twice as long to do it. Additionally, some of the feedback we received, which we thought was really interesting, was folks really wanted more specific feedback on the questions. So the first set of questions we put out in these would sort of say, nope, you're wrong, but not necessarily tell you why until you went back and reviewed the content. And then you could be like, there it is. And it didn't necessarily break down why this choice was right and why that choice was wrong in a specific way. Like you had to read the content, draw that conclusion, and then do the question again. Our learners really wanted to hear, our type A, medical friends really wanted to hear like why what they chose was wrong versus the other, and get much more immediate feedback on those questions. So we thought that was fairly interesting. We built that into our second version of the modules as we re-put them out there. I would love to rerun the study to see if I could really demonstrate a difference between these things. I think I'm going to have to choose a different procedure as my pretest, but I would like to see, I liked the idea of this, and now that I can get folks back in person more reliably, I would like to run another version of this. And maybe I'll bring this to one of our bag lunches and sort of chew on the right way to do it the second time. And then maybe some future research, sort of apples to apples, is maybe we bring in virtual reality and look at that versus the autism, sort of high tech versus high tech, to get a little more apples to apples, a little more engaging versus kind of boring reading stuff versus the pretty cool technologically stuff, and see if that really makes a difference. If I can keep your attention in two different ways, looking at things that are a little more similar, and whether it's really the adaptivity that creates the learning versus just the high tech keeping your attention. And that is all I have to say for today. And again, just thank you so much for having me. These are really great talks. I really enjoyed listening to the other ones as well. And thank you to the IME and everybody for helping us make this project go.
Thank you, Dr.